Hi, my name is Megan, and I'm doing a report on a proposed total ankle replacement with a 3D printed Tyler component. First of all, the ankle joint is a hinged synovial joint responsible for sagittal motion. So that's the plantar flexion and the dorsiflexion of the foot. It's comprised of three different joints, but most commonly known as the tibio-talar joint, but it is also joined with the fibulo-talar joint and the tibio-fibular joint, which altogether creates that ankle joint. It's formed between the tibia, the fibula superiorly, and the talus inferiorly. When it's put together with the subtalar joints below, it actually creates a universal type joint, which allows for that side-to-side motion, inversion, as well as the plantar flexion and dorsiflexion. Ankle anatomy is pretty complicated, as you can see in the structure to the side of your screen. It is created primarily with the tibia, fibula, and talus, forms a ring-like structure that creates a stability of the joint and actually secures the talus without any muscular connections. There are point protrusions seen on the outside of the ankle, inside, outside, back of the ankle. Those are referred to as the medial malleolus, which is at the tibia's base inside the ankle, the posterior malleolus, which is on the back side of the ankle at the tibia's base, and the lateral malleolus, which is the distal end of the fibula on the outside of the ankle. Now, as you can see, there are many different ligaments throughout the ankle, but there are three major ligament types. There's the tibiofibular ligament that connects the tibia to the fibula, the lateral and collateral ligaments, which attach the fibula to the calcaneus, giving the lateral stability of the ankle. And then the medial stability of the ankle is given by the deltoid ligament, which is attaches the tibia to the talus and the calcaneus. Ankle arthritis is occurring in patients who have worn out cartilage at the ankle joint. It's pretty common. About 1 out of 10 patients suffer with varied degrees of ankle arthritis, but it's actually only 1/9 as common as arthritis of the knee or the hip. This damaged cartilage can lead to malalignment and spacing issues within the joint, could lead to bone-to-bone contact, which is very uncomfortable for the patient and painful. Symptoms vary anywhere from pain in the ankle joint, which is worse with movement, which would be your less severe cases, all the way to the later stages of nocturnal inflammatory pain leading to instability, locking, and stiffness. Patients with ankle arthritis are usually either elderly patients presented as a primary degenerative arthritis, other comorbidities, or younger patients with post-traumatic arthritis resulting from previous injuries. Post-traumatic is actually more common than your osteoarthritis or your primary degenerative arthritis. This is created by fractures or chronic instability, which alter the joint's biomechanics. So it's something that is done to them. It's not genetic like osteoarthritis or from being overweight in a sense, because that adds more weight to the weight-bearing joints, causing osteoarthritis, but post-traumatic arthritis is a lot more common. There are many different treatments of ankle arthritis depending on the severity of the arthritis. Non-surgical approaches should be explored first, especially with less severe cases of arthritis. In that case, you would use your injection type, so that's more of a short-term relief for a long-term degenerative problem. But when it's still in the early stage, it is highly recommended to use those injections as long as you can. And then there's also ankle arthroscopy, which is a minimally invasive surgery with cameras and small surgical tools to just clean up the tissues within to create less pain for the patient in the long run. You could do osteotomy, which is a realignment of all the bones to create better joint spacing, or ankle distraction arthroplasty, which is not as commonly used, but it uses mechanical unloading of the joint to reverse effects of arthritis. The gold standard for treatment of arthritis is ankle arthrodesis. This has been used for decades as the gold standard, as it fuses the tibia, the talus, and the calcaneus bones. As you can see in the structure to the side of your screen, it uses screws to connect these bones as well as a plate secure the talus bone to the tibia. Advantages of this, it eliminates motion and provides stability within the ankle, leading to pain relief. Although, with the stagnant motion of the ankle, it disrupts normal gait, which can lead to complications in adjacent joints. In those adjacent joints, you could have any type of arthritis caused by this, or a type of pseudoarthritis bringing pain to those adjacent joints. Less commonly used, but should be more commonly used once further studies are made, is a total ankle replacement. It contains a talus and a tibial component to rebuild that tibiotalar joint, as you can see in the picture to the side. It's all the way back to the 1970s, with many advancements leading up to the current and third generation in use today. It's a semi-constrained structure using polymers as weight-bearing surfaces. Also, a lot of complications in this, but that leads to any surgical complication in general. Advantages of this are to maintain that range of motion while still decreasing pain and being cost-effective, which could lead to further advancements. Although there could be aseptic loosening of sorts, and revision surgeries usually happen between 5 to 10 years, which is what we want to improve. A 3D printed talar replacement was proposed and explored by Schnall to create a 3D printed total talar replacement. And how they did this is they did MRIs and X-rays and CT scans to measure the talar height, width, and length with those X-rays and MRIs, and the CT scans gave a 3D model of the patient's talus. Can be adjusted depending on the amount of damage and the current talus, so it can fit correctly within the body. This method of treatment is beneficial to those who have severe talus deformities, either from a talar injury or post-traumatic arthritis. Talus has no muscular attachments. It has a firm fit between the surrounding bones, leading to very little motion to protect itself from dislocation. So there's no need for any attachments to keep it in there. It pretty much keeps itself contained without dislocation. So I'm proposing a combination of the total ankle replacement and the 3D customized total talar replacement. A practical alternative to the gold standard of arthrodesis, as well as the total ankle replacement and total talar replacement, for cases of patients who have severe talar injury and still want to maintain their range of motion with after the surgery. Eliminates the possibility for misfitted implants, which actually is pretty common between these replacements, and it can be converted from failed total ankle replacements. So as I said, there are multiple different revision surgeries that may be required afterwards. So this can actually be converted by implanting the customized 3D printed total talar implant, as well as the new total ankle replacements, such as like the talar component, which would be the new 3D printed component, and the tibial component. So for design considerations, I would like to keep Schnall's approach by using the MRI and X-ray imaging and CT scans for the measurement and customization for patient to patient. And the talar component will be printed with alumina ceramic for its resistance to wear and corrosion with a high mechanical strength. Although you could also use a cobalt chromium, but a lot of patients have allergies to cobalt, so that might not be beneficial for everybody. Tibia and possible fibular components, depending on the type of ankle that needs this, will be of titanium alloy with a polymer pad to create cushion between the two. Ideal candidate for this would be someone of 50 years of age or older, with a body mass index of less than 30 and no severe comorbidities. You don't want an overweight patient due to an increased load on the joint could lead to wear and tear route and overuse. And then any comorbidities such as diabetes, poor circulation, heart and lung disease puts them at a higher risk of infection or wound healing after surgery. So they might not be ideal. For a testing protocol, preliminary testing, obviously you have to go through your FDA requirements. For example, corrosion rates, make sure they're below the legal amount. A way to test this would be for a model of the foot and ankle with the proposed replacement containing the customized implant, tested in gait with multiple different body weights. You want to make sure you get obese versus healthy, or a male versus a woman, considering a woman smaller, that sort of thing. It is imperative that the patient does post-operative rehabilitation for the device to work. They should follow the instructions given by their doctor and their physical therapist for the best results. Example guideline for this is 6 weeks. They should be fully non-weight-bearing, transitioning at 8 weeks to full weight-bearing a supportive shoe. It's predicted around 11 months for a full recovery. And to be able to test this, if this product worked, the surgeon should perform range of motion tests compared to the preliminary test given before implementation, as well as pain level tests, and to see if this idea works. If you have any questions, feel free to email me. I'll be sure to give you a quick response. Thank you.